Rolling down. Good afternoon and a very warm welcome to NITRD CTD NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome our DDG Sir, Dr. R.P. Joshi, directors and team from NIRT and NTI, STOs, directors of STDCs, faculty of medical college, district TB officers, medical officers and others. A very warm welcome. Introducing the faculty from NITRD, I am Dr. Neeta Singla, Nodal Officer DRTB Center at NITRD. On my extreme right is Dr. Rupak Singla. He is consultant in Department of TB and Respiratory Diseases. Next to me is Dr. Sangeeta Sharma. She is head of the Department Pediatrics at NITRD. On my left is Dr. Alok Yadav. He is CMO in Department of Pediatrics. And behind me is Dr. Saroj Meena. She is the senior pulmonologist at NITRD. And we have Dr. Reshma, Junior Resident in Department of Pediatrics. Now I request our Director, Sir, Dr. R.K. Diwan, to give his introductory remarks.
Good afternoon, everybody. I'm so happy to see that more than 140 participants have already joined in our so popular difficult to treat TB clinic. This clinic is especially important because this time we are doing on pediatric TB. I think most of you must be aware that pediatrics TB has its own dimensions and some more aspects for which the institute, NITRD itself, has been in the forefront to frame guidelines for management of pediatric tuberculosis, especially other than the standalone tuberculosis or adult tuberculosis. We have been involved right from early 2000s, in the first decade of the 21st century. We have been participants in framing guidelines for pediatric tuberculosis, and the fact that so many cases of even pediatric age group continue to suffer from TB is itself a very disheartening feature of our program and the scenario in our country. And if one visits NITRD, one will see that very serious cases of even drug-resistant and extremely drug-resistant TB are also prevalent in the pediatric age group. So the challenges, situations, and there are many cases of facing several complications. I, as thoracic surgeon, have even operated several cases of pediatric tuberculosis also. So there are many dimensions to pediatric tuberculosis, and our own Department of Pediatrics, headed by Dr. Sangeeta Sharma, has a very rich and vast experience in several nuances and complications relating to this field. I'm looking forward to this presentation again today, as in every other case of difficult to treat TB clinic. And on behalf of the institute, I thank everybody who has cared to join in the middle of the day for this session. I can see very renowned figures like Dr. Jai Kishan, the DDG TB, Dr. Anand Agrawal, Dr. Rishi, and several others who have joined. And I'm sure we will be enriched by whatever interactions and interjections which are made by various participants. Thank you so much for having joined, and best wishes for the clinic. Over to you, Dr. Neeta. Thank you so much.
Yeah. Thank you, sir. Thanks a lot. The DDG sir is going to join us, but he's delayed. So I will let you know whenever he joins. So regarding today's session is contributed by a project by the organization FIND. This organization focuses on providing the technical assistance to assess quality services for DRTB management for the pediatric age group in 3 states, namely Delhi, Maharashtra, and Madhya Pradesh. The project proposes to conduct capacity building sessions and workshops for all cadre of health professionals to fill in the gaps of pediatric TB management. So we thank FIND for contributing this session. Today's case is being presented by Dr. Reshma. She is junior resident in Department of Pediatrics at NITRD, and the case expert is Dr. Alok Yadav, who is CMO in the same department. The national expert for today is Dr. Sangeeta Sharma. She is professor and head Department of Pediatrics at NITRD. She is also the in charge for National COE for Pediatric TB and DRTB at NITRD. She has several publications to her credit. So we welcome Dr. Sangeeta, and over to Dr. Reshma for case presentation.
Good afternoon, everyone. I am Dr. Reshma. I'm going to present the case of a 14-year-old female. She is a 9th standard student. presented to our pediatric OPD in an NITRD on 9th of October 2023. And her height was 150 centimeter, weight was 40 kg, and the BMI was 17 kg, which is -1 standard deviation to the mean. And the history starts in 2021 September. The symptoms started with abdominal pain from 1 month at the time of presentation, which was continuous, diffuse, dull aching pain without any radiation or progression at the epigastric region. The pain is not associated with nausea or vomiting, not increased or decreased with food intake, and her bowel and blood habits were also normal. And she had a single episode of coughing out of fresh blood around 100 ml at the time of presentation. And there was no associated fever or cough or any documented, and she also had, she didn't had any documented weight loss as observed by parents. This is X-ray at the time of presentation is attached. And for these symptoms, she got admitted in nearby private hospital. The ultrasound abdomen and upper GI endoscopy was done, which was normal. Other routine investigations were also normal. So she got symptomatic treatment at the time and improved, and she got discharged. Then again, she was asymptomatic for the next 6 months. She again had started having complaints of cough from March 2022 with scanty mucoid expectoration without any purulence or foul smelling. There was no history of any postural or diurnal variation, no history of cough, bloodstained sputum. And she also had intermittent low-grade fever, which was not documented, and loss of weight and loss of appetite. For these complaints, she presented to the same hospital in March 2022. She didn't have any complaint of breathlessness or chest pain. No, there is no past history of tuberculosis or ATT intake. There was no history of contact with tuberculosis patients and no other comorbidities. And she presented to the same hospital. From there, she got symptomatic management, but she didn't get improved. So she got admitted in the same hospital in July 2022. Sputum examination was done. Sputum AFB and gastric aspirate AFB found to be positive. And in sputum CBNAT was done at that time. MTB detected and roof resistance not detected. According to this, the patient started on ATT, 4-FCC, 6-dose combination, 3 tablets per day from 21st of July. As per the patient attendant, she was adherent to the therapy. And at that time, HIV serology was non-reactive. She didn't have any symptomatic improvement, and at the end of the treatment, fever and cough with sputum was persisting, and radiologically there was new lesions also appearing on the right midzone and lower zone. At the end of the IP or CP, there was no sputum examinations were repeated. For these persistent complaints, she consulted the private hospital, same hospital. From there, gastric aspirate AFB was repeated, which was negative, and sputum CBNAT was repeated on December 26th of 2022. It found to be MTB detected and rifampicin resistance detected. And she was referred to the government sector, and she started on all oral longer regimen from 11th of January 2022. At that time, patient's weight was 37 kg, and she was started on bedaquiline, moxifloxacin, linezolid, clofazimine, and cycloserine. With bedaquiline 400 mg daily for 2 weeks, followed by 200 mg alternate day for 22 weeks. Moxifloxacin high dose 600 mg, linezolid 600 mg, clofazimine 100 mg, and cycloserine 500 mg. She had only, initially there was an improvement in the first 2 weeks, followed by worsening of symptoms. Cough and fever was persisting. Sputum cultures were done in April 2023, May, June, and July, and they were positive at the 3rd month, 4th month, 5th month, and 6th month respectively, and found to be positive. At the end of 6th month, in 27 July 2023, the culture was positive. Sputum gene expert XPR was done, which showed MTB detected, ethionomide, fluoroquinolone, INH, and second-line injectable sensitive. Sputum midget culture was done in 7th of August 2023, and it was reported in September 2023 14, and it came to be positive and bedaquiline resistant. Dilamanid, ethionamide, PAS, linezolid, clofazimine, and high-dose moxifloxacin were found to be sensitive. Sputum LPA was done in August 2023, and it showed smear positive, INH and rifampicin resistance not detected. These are the reports of gene expert and the midget culture, which showing the sensitivity pattern. She presented to NITRD OPD in October 2023 with chief complaints of persistence of loss of appetite and weight loss for the last 5 months. And we did the pre-treatment evaluation. They were within normal limits. At the time of presentation to NITRD, her weight was 30 kilograms. On the basis of extended DST report, all oral longer regimen was made and was started on 20th of October 2023. In NITRD, the sputum smear was 3+. Sputum CBNAT showed MTB detected, ref resistance not detected. Sputum first line LPA on 10th of October showed INH and rifampicin resistance not detected. Second line LPA showed fluoroquinolone, second line injectable sensitive. Sputum midget culture was also done from our hospital. That was in August of 2023, which showed culture positive and bedaquiline resistance. This case was discussed in DRTB committee, and she was started on moxifloxacin 600 mg, linezolid 600 mg, dilamanid 100 mg, injection amikacin 750 mg, ethionamide 500 mg, and PAS 40 mg, with effect from 20th October 2023 after pretreatment evaluation. This is a case summary that she presented in 2021 September. At that time, her complaints was abdominal pain and hemoptysis, for which she was evaluated, and the investigations were normal, and she was managed symptomatically. At the time, the X-ray shows left lower zone nodular infiltrate, and she again presented in March 2022 for cough with expectoration, and she got admitted in July and evaluated in July, and her sputum AFB became positive. Sputum CBNAT showed MTB detected and ref resistance not detected. She started on sensitive regimen of ATT with 4 FBC from July onwards, but her complaints were persisting. So she again evaluated in December 2022. At that time, sputum CBNAT showed MTB detected and ref resistance detected, based on which she was started on all oral longer regimen in 11th of January 2023. She remained culture positive on the 3rd, 4th, 5th, and 6th months of treatment, and the X-ray also showed deterioration with new patches, and the culture DST in August 2023 showed culture positive and bedaquiline resistant. She presented to our OPD on 10th of October. At that time, the X-ray shows right-sided mid-zone and lower zone consolidation with left upper zone infiltrates, and she was started on dilamanid based oral longer regimen in 20th of October 2023, and these are the follow-up X-rays on 6th and 20th of November. Thank you.
Thank you, Reshma. Very well presented. Thank you so much. And export for the case, the person who's been dealing with this case is Dr. Alok. So now I invite Dr. Alok Yadav, to brief us about the case and his findings for this case, and then maybe we open the house for questions. So, do I take the questions first, or
we can summarize.
You will summarize the case. Okay, so over to Dr. Alok.
My case, this case is, I am summarizing this case, a 13-year-old female residence of New Delhi, Rohini. Weight is 40 kg, height is 150 centimeter, BMI is 17 kg per meter squared. Comes under -1 standard deviation to median. In July 2022, patient present in a nearby hospital with the chief complaint of cough with expectoration, non-documented low-grade fever, and loss of appetite from last 3 months. Admitted for this patient was admitted an investigation in July 2022 for TB workup was done. Sputum smear was found AFB positive. Gastric aspirate was found MTB detected, but RIF resistance was not detected at that time. So patient, they referred this patient to the DOT center where 4 FDC 3 tablet of isoniazid 225 milligram, rifampicin 450, pyrazinamide 1200 milligram, and ethambutol 825 milligram was started in July 2022. Patient took ATD for 6 months till December 2022. Outcome of this patient is treatment completed because no sputum smear or culture done at the end of IP or the CP. This is the chest X-ray which was done at the end of the treatment, about December of the month. Next. In December 2022, patient again present with the complaint of low-grade fever and persistent cough for 7 days. And patient again go to the same hospital from where gastric aspirate was done, which was found AB negative, and sputum CBNet was done, which was found MTB detected and RIF resistance detected. For this, they referred this patient to the DRTB center, which comes in their locality, from where the oral PDQ-based regime was started from 11 January 2022. Bedaquiline, linezolid, moxifloxacin, cycloserine, and clofazimine. These drugs are started in January 2022. The dosage as per WHO is linezolid is 10 to 12 milligram, moxifloxacin 15 to 18 milligram per kg, cycloserine is 10 to 15 milligram per kg, and clofazimine is 2 to 5 milligram per kg. At that time, the weight of the patient is 37 kg. So bedaquiline is started 400 milligram for 2 weeks, then next 200 milligram 3 times per week for next 3 to 24. And linezolid is 600 milligram, moxifloxacin is 600 milligram, cycloserine 500, and clofazimine is 100 milligram. Then in the routine cultures was done in the DRTV center. First culture was done at the 3rd month, which was found positive, and 4th month the culture was found positive. At the 5th month culture was found positive, and 6th month culture was found positive. At the end of 6 months, they sent the culture, they sent the expert DRTB. In this, MTB was detected. Isoniazid, fluoroquinolone, second line injectable, and ethanamide was found sensitive at that time. In next 7 month culture was found positive. They sent this sample to NITRD for extended DST. In NITRD, the reports was available on 9th of the month. Bedaquiline was found resistance and sensitivity for the linezolid, moxifloxacin, high dose clofazimine, PAS, delaminid, and ethanamide was found positive. At the end of 8th month, culture was found positive, and the LPA report, first line LPA, so rifampicin sensitive, INS and CATG mutation was not detected. In the NITID, when this patient come, we do the LPA. At the end of 9 months, LPA smear was found positive, rifampicin, isoniazid, and INS was found sensitive at that time. Next. So patient presented to NITID October 2023 with extended DST report. Weight at that time is 30 kg, height 150 centimeter, BMI 13.33 kg per meter square, comes under -2 standard deviation to -3 standard deviation. The patient comes in our OPD with the persistent cough, loss of appetite, and weight loss from 4 to 5 months. We do the pre-treatment evaluation, CBC, RBS, urine, routine microscopic, LFT, KFT, thyroid, chest X-ray, HIV, ECG, audiometry was found within the normal limit. After the pre-treatment evaluation on the basis of extended DST reports, all oral DRTB regimen was started. That this was the X-ray at the time of the presentation. So drugs which we are using as bedaquiline, that next bedaquiline was used and also found resistance, so we didn't add in the regimen. Next is fluoroquinolones, moxifloxacin, that was used and also found sensitive, so we used in the regimen at 600 milligram. Linezolid was used but found sensitive, so we used 600 milligram. Clofazimine was used but found sensitive, but we didn't used in this regimen. Cycloserine was used and sensitivity are also not available, so we didn't use this in our regimen. Delaminid was not used and also found sensitive, so we add in 100 milligram. Amikacin was not used and also found sensitive, so we use amikacin at 750 milligram. Pyrazinamide was used and sensitivity pattern also not available, so we didn't add in our regimen. Next, ethionamide was not used and also found sensitive, so we use it 500 milligram. PAS is not used but found sensitive, so we use at 14 milligram as per body weight. And ethambutol was used, so we didn't add in our regimen. Next. So final regimen from the NITRD is moxifloxacin at 30 kg weight, linezolid 600 milligram, delaminate is 100 milligram, injection amikacin 750 milligram, ethionamide 500 milligram, in PAS is 14 milligram. That is it.
Thank you so much, Dr. Alok. And now we open the case for discussion. Any questions on history or treatment of this patient? Yeah, Dr. Saroj, there is a question, please.
Yes, so there's a question regarding the nutrition supplementation. For the first time when the patient received TB treatment, whether she got any nutrition supplement or not. And there's another question is the treatment which was done before start of the sensitive TB treatment in 2022. Was it done in a government setup or is it in a private?
So regarding the first question, nutritional supplement, patient is comes under a middle income group, and as per the nutritional statement, patient is taking the adequate nutrition, whatever the parents are given. And in the CBNet, the first time CBNet was done in a private hospital. That is not a government hospital. That is a private hospital where the patient was admitted. So first time the CBNet was done in the private hospital.
Okay, so there's one more question, sir, on the drug absorption study. Did we did the drug absorption study in this patient?
No.
Or it was done like in the when she was treated in the private, was it done at that time?
No, in this patient, the patient comes in the NITRD in October 2023. Before that, patient has already taken the treatment DRTB regimen from another DRTB center, and before that he took the treatment from the private hospital. So there is no such drug absorption study was done.
No, but I would like to add, we are thinking of getting these done because all the tests, starting from the initial, in the beginning, this child was sputum smear positive and RIF sensitive. So, and then the child was started on a good regimen once it was RIF resistance. And despite the regimen and good compliance, the child remained culture positive. And so this is one thing which we are also thinking, and we would be sending the blood. That's a very important question which has been asked, because despite a good adherence and a regimen which is based on the sensitivity pattern, your patient is not improving, you should always get the PK status known of the drugs. So blood sample, three samples are ideal. One is just before in the morning, before the child has taken the drugs, and then give the child breakfast along with the drugs. That is a sample, which is then the second sample is repeated immediately after taking the drugs after 2 hours, and then finally at 4 hours. So, I mean, that's a very good question, I must say.
Thank you, Dr. Sunita. Yeah. Any questions, please raise your hand or you may ask. Unmute. Yes, yes, Dr. Anand, please.
Yeah, the one thing which is important, the absorption, that is important indeed, because if we see the progress of the disease and the regime which has been used, the absorption always matter. But the one thing which is also matter, the quality of drug, because if absorption will be the culprit, then the last regime which has been used finally by the NITRD, that should also not worked in that patient, though it has not happened. The final regime which has been used by the NITRD, that has been successfully worked in that particular patient. So we can also think that whether the quality of the drug which has been utilized by the previous center, that has been compromised, because the repeated positivity as well as the resistance that gradually get developed may also raise a questions on the quality of the drugs, as well as whether the patient took these drugs regularly in
I think that is
of
very
the
important
drugs
point which you are
provider or
highlighting,
the
you
family
know.
members, or there is some.
That's very important point which you are highlighting. Over here, we repeatedly asked, there was good adherence, and the drugs were taken from the DRTB center. So the quality of drugs was not at stake. And with the treatment which we have started, there just 2 months over. I mean, there is a early improvement which happened even at that time. That time also the child improved in the initial part, but later on started to deteriorate. So all these things we are taking into consideration. A very important thing which you have said.
Another important point is that whether the patient took all these medicines simultaneously or in the morning or evening shift, there are some factors which may be related to the history part if it will be taken precisely.
Yeah, that's another very important thing, especially, to take the drugs with light meal, to avoid milk when you're giving fluoroquinolones because calcium decreases the absorption. So all these things, the parents are quite, well versed. So hopefully that should not be an issue. But obviously, another important point which you've raised.
So, Dr. Anand, taking your point, within the program, the quality of the drugs is assured. So there are, it is
Also,
unlike,
many,
because
many a
each and
times
every
they
batch
kept.
is insured. But yes, we have to think of adherence because with children, adherence can be an issue, even if parents are, very conscious, then also, child would emotionally blackmail or not take or, hide the medicines. Yes, those issues, definitely operational issues are there, right?
Yeah.
Yeah. So any other question? Yeah, so Dr. Alok, there's a question which says when third and fourth month culture report was positive, patients should have been reviewed for addition of delaminate and injectable.
Actually, this patient, the third and fourth month culture was done in another DRTB center, and they send the culture at the end of 6 months for the extended DST reports. So definitely at the end of the third and fourth month, the culture reports were found positive. This patient should be reviewed, but this patient, this patient comes the extended DST. This patient, the culture comes for the extended DST to our institute at the end of 6 months, and the patient come at the end of 8th month. So we design the regimen as per the extended DST reports at that time. But definitely at the end of 3/4 month.
I think fourth and fifth month
Fourth, fifth.
should, third month, Dr. Singla. I feel it is too early, although because conversion sometimes can take a bit longer. But obviously, after fourth or fifth month, it still, because in this case, persistently the cultures they were positive. So that is a alarm bell which we should have rung earlier, something like fourth or fifth month, that the child is not converting.
So you see, as per program guidelines, it is clear in case patient is deteriorating clinically and we find cultures are positive. So the fourth month culture, the report will come by around 6 months. So this culture must be subject to extended DST to really know whether we are on the right path or not. Meanwhile, we'll have 5th month culture, 6 months smear also, which will again guide us that what should be done. So that is a very valid point that in case the culture at 3rd month, 4th month are positive, we need to review the treatment regimen.
Dr. Shiv from Ottawa, sir, are you asking a question? Okay,
There's one more question.
yeah, Dr.
Ma'am, there's one more question on WGS, whether it has any role in this patient and does the addition of RMP in this regimen will help?
Yeah. So I totally agree with this, that because once this patient reported to us, we got all the microbiological tests repeated. Sputum was smear was 3+, CB-nat RIF sensitive. First line LPA, second line LPA shows all sensitive, and rifampicin even is coming sensitive. So I mean, I agree that rifampicin could have had a role, but then we also need to remember, there are some gene mutations rather than RPOB. There are other mutations alongside RPOB that might be responsible for the child not responding to rifampicin. So here comes the role of whole genome sequencing or next generation sequencing. The other thing which is important is once we have bideckelin resistance, we also need to know which is the gene responsible for the bideckelin resistance, because over here we are missing on clofazimine in the regimen. Bideckelin resistance, for information of house, is caused by ATPE, which is only pure bideckelin without clofazimine class resistance. While RV067, RV1959, as well as PEPQ, they have both bideckelin as well as clofazimine resistance. So for rifampicin as well as for clofazimine, we are getting the NGS and thinking of getting both the things, that is PK levels as well as the genome sequencing. So this is a very important thing because we need to look. And the other thing which prompted us to get this case over here is, we all know that bideckelin, we have resistance of about 2%, which is reported. But now, in the recent, I have had two cases. One is this one, another child who are BDQ resistance. So once we are designing the regimen, to design a regimen in children, there are few things which we need to take into consideration, which are different from adults. So that is the reason I want to just, for the information of the house, one is the severity. Because now we have regimens, as we are all aware, shorter MDR-TB regimen and as well as the longer MDR-TB regimen. So for the shorter MDR-TB regimen, criteria is severity. Severity criteria for children, they are different from adults. In child, if there is a presence of cavities or a bilateral disease, miliary pattern, so even for you, and the involvement should not be more than 1/3 of the lobe. So that is, if the involvement is more than 1/3, that is a severe disease. Then for extrapulmonary TB, again the criteria are different. For children, only one extrapulmonary TB is included as a non-severe, that is peripheral lymphadenopathy or mediastinal lymph node, hilar lymph node, not causing any obstruction. Rest all, be it GIT, be it genitourinary, they all come under the category of severe disease. So one is we take into consideration the severity, and the other, for the information of the house, is the drugs. The drugs which can be used as per WHO, now all these drugs, the newer drugs, that is bedaquiline and delaminate, they are recommended to be used in children of all ages. But as per DCGI, India, we have the approval to use bedaquiline in children more than 5 years as well as 15 kg. So both the criteria should be there. If the child is 6 years but weight is 12, so we won't be able to start bedaquiline. So both the criteria for bedaquiline should be there. Now regarding delaminate, delaminate can be used in infants who weigh more than 10 kg. So, so the age as well as weight criteria, any child who's more than 5 years, just check the weight. So the child could be eligible for bedaquiline longer as well as shorter regimen. Now, if the child's age is less than 5 years, then you need to check the weight. So if the weight is more than 10, then the child can be given the delaminate based regimens. While if the weight is less than 10, then obviously we have to go ahead and start the injectables. So these are the few things which are different from adults, which I think the house needs to know once you're designing a regimen for children.
There are a few more questions in the chat box. One is like the patient who's having unilateral lung disease. So, is there any role of surgery in this such kind of a patient?
Dr. Devan sir, your comments would be welcome on this. Dr. Devan sir, I think sir is not here. So,
I would say that if the disease, but in this case, the disease is not unilateral. So there are shadows on the other side also. But obviously, if the disease is unilateral and it is confined, there is a role of surgery. Definitely, there's a role of surgery. And the ideal time to conduct the surgery is 6 to 9 months post when the treatment is ongoing.
But I think we need to clarify in this case, it's a bilateral disease.
Bilateral disease.
So
So
surgery
not
is
eligible for
not
surgery.
recommended.
One more question, like the nutrition status of the child was poor since the beginning. So what advice shall we give to the parents to improve the nutrition status in such case?
So an important thing is that first what I do is I always deworm the child, because worms are very common. Whatever we give, they would be literally no use. So after deworming, and good thing is we have drugs like ivermectin, which takes care of both ecto as well as endoparasites. So give one dose right in the beginning, and repeat the dose after 15 days, because if there are any ova etc left, so they will be taken care of. And now coming to the nutritional rehabilitation, so most important thing to stress is that there is no need of inclusion of hi-fi things in the diet. If, depending upon the age, like in this child, the protein can be taken care of. If the child takes non-veg, so important is 2 eggs per day. They take care of, one egg gives 6 grams, so 12 grams would come from there. And whatever is available in the house, that is most important, that need, and the child needs to be included. And the other thing which is more important is, because the children they are literally miniature adults. So a good counseling is very important, because it's a psychosocial stress even for the child. So you need to explain to the child that you're absolutely getting well. Um, so the child is not mentally socially harassed, and takes care of the diet etc. So good balanced diet is what is important, rather than going for hi-fi things ki nuts badam zarur khilane, all these things it is good if you can afford. I don't disagree with that.
right.
So
Thank you, ma'am. Are there any questions, Dr. Saroj?
No, ma'am, there's no more
Okay,
questions.
so Dr. Singla, could you tell us, like, we spoke of WGS. So what, for the house, can you tell us what is the additional information that we get apart from LPA? Why do we suggest doing WGS?
You see this whole generation sequencing, next generation sequencing. The plus point is that it can tell us about the resistance to the first line drugs, second line drugs in a short period of time. The targeted genome sequencing can be done even on a direct sputum sample. While the whole genome sequencing, it requires culture to be done first and then followed by whole genome sequencing. But the thing which we remember, which we need to remember is the quality where it has been done. In case the quality is not ensured, in that case, we should not rely on the report of WGS. And that is whatever the opinion of NTP does. As of now, we do not have quality assured WGS with us. NIRT Chennai is doing it, so their help can be taken in such cases if it is decided to be done. Otherwise, many private labs are there which are mushrooming in the market who claim that they can do WGS. We should not take clinical actions based on those WGS reports.
Very important, I think. And the other thing important is that all the hidden, like in hidden mutations also come into forefront. So, but from a good accredited place.
Okay, ma'am. So, like you said that, there are certain guidelines for pediatrics, like you cannot give bedaquiline less than 5 years,
Yeah.
and you can give delaminate. So, what are the other things that we should remember when we are treating a child, or what our DTOs should know, remember things for pediatric management?
So I think I've already talked about this, but if you want, I can repeat it. One is severity of the disease. So severity criteria I've already highlighted that severity criteria as regards to pulmonary or enterothoracic TB are also different from what you have from adults. If the child is smear or culture positive, that is definitely goes towards severe disease. So we need to remember that. So CP-NAT can be positive even for non-sphere, but if the child's sputum smear or culture sputum smear is positive, that means the child is having a severe disease. Presence of cavities, then miliary pattern, and involvement more than one third of the lung. So bilateral or if the whole lung is involved, so that automatically goes towards the severe disease. Now, then there should be uncomplicated pleural effusion. If there is pleural effusion, it should not be complicated. That means there should be no bronchopleural fistula, empyema, etc. So, uncomplicated pleural effusion is non-severe, but moderate to severe pleural effusion with the other complications becomes a severe disease. Then comes the intrathoracic lymph nodes. If there is presence of the lymph nodes, they should not be causing any obstruction. So mediastinal lymph nodes can be there. So that is non-severe disease, but without obstruction. If there is obstruction, then it automatically goes towards the severe disease. So this is for the pulmonary TB. Now coming to extrapulmonary TB, as I've already said, so extrapulmonary only peripheral lymphadenopathy, as well as if there is peripheral lymphadenopathy or mediastinal lymphadenopathy, which is not causing obstruction. These are the only EPTBs which are included under the non-severe category. Rest all, be it any involvement of the organ, GI, genitourinary. Obviously, other as for adults, you have CNS tuberculosis, miliary tuberculosis, osteoarticular tuberculosis. They are all, even for adults, they are considered under severe category. Same applies to children. Not EPTB with HIV can be in non-severe also. So that is also very important. So if the child is having HIV positive, so that is not a criteria to decide the severity. The only thing which we need to take care designing a regimen if a child is HIV positive is that we need to remember the interactions like bedaquiline with efavirenz and then also other antiretrovirals, and also let the child be stabilized on the MDR-TB regimen, and then try to introduce the, if the child is already on ART, then we have to look at the ART, which is also age-based criteria. Our ART regimens are also age-based. So for children more than 10 years, we have ZLD, that is zidovudine, lamivudine, as well as dolutegravir. So once you start ATT, the only difference in this age group is that your dolutegravir becomes BD. And then less than 6 to 10, then you have the ALD regimen, that is abicavir comes into picture. And less than that is abicavir, lamivudine, as well as lopinavir and ritonavir. So now lopinavir and ritonavir, they have an interaction with bedaquiline. So that is thing which we have to take care of. We have to increase the dose of ritonavir. So that is called the ritonavir boost. And these, if the child is not on ART regimen, then these are the regimens which we will start. And after starting the ATT, the MDR-TB regimen, the child should stabilize. So the ART is introduced depending upon the stabilization status of the child in 2 weeks to 2 months. So we expect within 2 months that you should be able to start your ART regimen. And the other thing regarding the age criteria
That you've already
that I've already said, and those apply.
Yeah. Thank you, ma'am. So before I take your comments on treatment part, can we have the questions, the two questions?
One more question is there, ma'am. I think it's on the poor appetite these children have, TB children have. So any role of cyproheptadine in
No,
this patient?
no.
Cyproheptadine.
No, cyproheptadine, please don't use it because it's an antihistaminic, It leads on to the CNS depression of the child. So if the child is having anorexia, just get the LFT done. If the LFT is because some LFT rise is expected, but it should not be more than 3 with symptoms and more than 5 without symptoms. 3 times, I mean. So otherwise, if the child LFT is normal, then it could be due to the GI irritation. So in those cases, if we are giving bedaquiline, better is to give with vomiting, that is perinom, that is metoclopramide and Rentec. So
Yeah.
keeping in view the bedaquiline part.
So, are there? Yeah, there was one question on CT scan.
It just should have been done. It was done in the past.
Oh. So, ma'am, what are your comments on the treatment now? How do you plan to treat this
Yeah.
patient?
So now over here, I plan to, there could be a change in this regimen because I feel we need to also, one thing is we'll get the blood levels done, that is the PK levels. And the other thing is also get the NGS because there could be hidden mutations to rifampicin, as well as to decide on the role of inclusion of clofazimine in the regimen. Because bedaquiline, as I already discussed, bedaquiline could be co-associated with the clofazimine, but that is dependent upon the mutation which you have. So if there is ATPE mutation, then we can safely give clofazimine. In this case, so after these two, there could be a role of inclusion of rifampicin in the regimen because all the tests which are being shown over here, that is the first line LPA shows rifampicin sensitive, the CBNAT shows rifampicin sensitive, and the extended DST just shows bedaquiline resistance. So the regimen which I think I would propose is that rifampicin included after we get the reports of the NGS, levoflox or moxiflox, either of the two, and then linezolid, clofazimine, depending upon again the report of the NGS, and then comes delaminid. Next drug which I think is either amikacin or pyrazinamide. Now over here we don't have the report of pyrazinamide in our detailed extended DST. So the only thing is to continue amikacin. But then once we are giving amikacin, we need to remember that there is, we need to monitor the child audiometry every 2 months. So this is the regimen, what do you think, Dr. Singla? Is there a role of inclusion of rifampicin? Because all the tests, they are now showing that it is rifampicin sensitive.
Okay, can you open this slide? Just in a single slide, I like to discuss this case. Most of the things have already been discussed. You see, as if you see from the beginning, patient was rifampicin sensitive pre-treatment, that is July 22. And after that, he was put on good drugs, but did not respond. And then in December 22, the rifampicin was found to be resistant on CBNAT. Now, while on the DRTB regimen, which was started somewhere in the January 2023, patient was again deteriorating, and all the culture, 3rd month, 4th month, 5th month, 6th month, they were positive. But when you look at the sensitivity to INH and rifampicin, LPA in September 23, they say it is sensitive. October 23, they say it is sensitive. Expert XDR in July 23 also say it is sensitive. And even the latest one, it says both INH and rifampicin are sensitive. In this case, compliance, as has been presented, was assured. There was no obvious evidence of immune suppression. In that case, the one of the cause which can explain the entire presentation of the case is there could be low blood levels, since the patient is not responding to the first line drug as well as second line drugs. Now, what will do after the blood levels are done? There can be two scenarios. One is blood levels are normal. Second is blood levels are low. So, in case the blood levels are normal, in that case, that means there is we have practically ruled out the possibility of poor absorption. So in that case, we will choose 4 new drugs which patient has not taken before, which was shown by Dr. Alok. delamanid, amikacin, ethonamide, and PAS. So this will be the very effective drug, because whenever we talk about the which drugs should form the regimen, if drugs have not been taken and they are found to be sensitive, they are the first drugs to be considered. So these drugs, delamanid, amikacin, ethonamide, and PAS, they are fulfilling these requirements. And to this regimen, I may add moxi high dose and linezolid, although they have been taken. And please see, in case somebody is already on treatment for 7-8 months, even if the midget culture says it is sensitive, we may not rely too much on that. The reason being, these culture DSTs, they are good in case they find it is resistant. But still in 10-20% of cases, especially for linezolid, clofazimine, they are likely to miss resistance even if it is present. So these 4 drugs, I may add moxifloxacin high dose and linezolid, because the midget was showing it is sensitive, just to give benefit to the patient. So now we are not adding clofazimine in this regimen. There are 2-3 reasons. One is, as already discussed by Dr. Sangeeta, the chances of cross reactions with daclofenac are quite high, and we do not have the genetic mutation pattern, whether it is ABGE or RB07678. So unless we have those things with us, we cannot consider the clofazimine to be a good drug in this case. And also, we should not ignore, you see, this child is 14 years of age and has already taken clofazimine for 7-8 months. I am sure her skin color must have become brownish black, scaly. So these are the side effects which we cannot ignore, we should not ignore, especially in the children, especially in the girls who are at younger age group. And also, we want to reduce the pill burden. Already we have suggested 6 drugs, delamanid, amikacin, ethonamide, PAS, with moxi high dose and linezolid. So adding a 7th drug, which is very, very doubtful and has adverse events, I will not recommend to add that. Now, second scenario is the blood levels are low. Then what is to be done? So in that case, we think if blood levels are low, that this patient is not absorbing the drugs, whether it is first line drugs, and we are not sure that she will absorb the second line drugs as well, because there is no reason to say a person is not absorbing the first line drug will be absorbing the second line drugs well. So in this case, what we do is we try to give as much injections as possible rather than the oral drugs. In case we have documented blood levels to be low, we try to give in the regimen more of injections. Although I know in children it's a very big challenge to give injections, and especially like the amikacin, kanamycin and all, they can cause the AIDS nerve toxicity. So we have to monitor that very closely. So in case the levels are low, the recommended regimen, which I think could be delamanid, amikacin, ethionamide, PAS, not taken in the past, and then injection in moxifloxacin, because injection of this moxi and levo, they are available. In this case, I may think of adding injectable INH and rifampicin. Fortunately, bedaquiline is not a part of this regimen. So rifampicin interaction with bedaquiline will be avoided, will not be there. So to these 5 drugs, if somebody adds injection INH and rifampicin, I think it can be considered. The reason being, if they are effective, they are very effective drugs. And repeatedly we find HNR sensitive. So in this case, we can give benefit to the patient. We have found a good regimen with the 4 new drugs, injection amoxicillin, which is found to be sensitive, although used. So in addition to these 5 drugs, we may add injection INH and rifampicin. And to reduce the pill burden, we may not consider linezolid clofazimine, which patient has been taking for last 8 months. So they are very unlikely that they will be effective. So in these 2 scenarios, blood levels are normal, I have suggested the regimen. If the blood levels are low, I have suggested this regimen. That is my take on this case. Thank you.
Thank you, Dr. Singla. Dr. Saroj, there was one comment on use of rifampicin by Dr. Vijay Chauhan. Dr. Vijay, are you there? He had apprehensions of using rifampicin, saying that it should not be used because
Yeah, you have already covered. You see.
Yeah. There. No, I agree with sir. I agree with sir saying that but I was worried about the enzyme-inducing effect of rifampicin also on delamanid. So since this patient had already taken rifampicin, failed that treatment for 6 months, and has not responded to linezolid. So linezolid, moxifloxacin. So adding another drug, rifampicin, which is an enzyme inducer, with the possibility of having drug levels on other drug levels. So considering that, I thought that it is best to continue with the regimen that sir has, and then see how we go along, because adding another drug would be adding one more drug to the regimen.
You see, Dr. Vijay, you have a point, and it cannot be denied whatever you are saying. Only issue is repeatedly the INS sensitive, rifampicin sensitive 3-4 times, and the blood levels are normal.
Blood levels, if we are able to get hold.
If you are able to,
Yeah.
that's why I gave 2 scenarios. In case we do the blood level from a reliable laboratory, and we find it is the levels are normal, so then only in view of the repeatedly sensitive reports, I think that we may consider the INH and rifampicin, because if they are effective, in case person is sensitive to the bacteria, although chances are less, chances in the, if you look at the presentation, in the first instance when they were given, patient failed to treatment. But now there is a gap of last 8 months.
No,
In these
more
8
than that,
months,
almost like
9-10 months. And in these 9-10 months, patient had not received INH and rifampicin. Rather, patient has received linezolid, clofazimine, drugs like that. So although even if they are sensitive, considering the sensitivity of the linezolid and clofazimine resistance given by Biject, in 10-20% of cases, it can be missed. So it could be resistance, but not the lab is not telling us that it is resistant. That is known thing with Biject DST. So considering all these points, I feel that we may consider INH and rifampicin in this case.
Yeah, thank you, Dr. Singla. And
Thank you, sir.
Dr. Rajendra Prasad sir is there. Welcome, sir. Sir, you wanted to make a comment. Sir, you're muted, sir. Sir, we are not able to hear you. Mute करें? नहीं, वो आप नहीं कर सकते.
Hello, good morning.
हाँ,
Ji sir, good morning.
Good afternoon, rather. I was
Afternoon.
actually I'm traveling, but I have listened everything. I must say, a very brilliant discussion by Rupak and then Sangeeta and other people. What we are thinking, I agree with Rupak that every time probably the reliability of these tests may not be as good as we think. And this, I'm not saying for the first time, I'm teaching these cases for last maybe 30 years. And we have shown cases where there are different reports, even with newer tests like LP1, 2, and culture you have seen. So different results are there. Well, only question to me is where we are going. In this case, what I have heard, there is a betacholine resistance also. But anyhow, we have to save the life. And probably the disease is mainly confined, though 2 things I interpret, 2-3 things. One is that reliability of these tests is a question mark. Second, drug, we cannot question mark the reliability of the drug because they are from the PMDT side, and where all quality control and everything is being monitored. Third thing, I will say that patient is a very difficult case. There is no doubt about it, whatever is the region. So in this scenario, disease is mainly localized. I mean, when we used to treat, although conventionally we say that disease should be unilateral, but sometimes we say that if bacteria is a very difficult, which is obvious, and then if the disease is even maybe on the opposite side, little disease is there, if a daring surgeon like Dr. Diwan and others can think of opting for surgery at appropriate stage if it is possible. That these are the things which might save the life of the patient. That is my I'm sorry, I'm traveling. Actually, I have lost my elder brother, so I came from his rituals. So, but I was listening for literally whole of the discussion, and I agree that case is difficult, and we have to be manage it very effectively so that we might save the life of patient. Thank you, Nita,
So much, sir. Thank you so much. Dr. Saroj,
Now, there was an observation by Dr. Vijay Chavan. He said when the child was presented initially with complaint of pain, abdomen, and hemoptysis, that time he was underwent endoscopy. So what he's suggesting it should have been done rightly. The CT scan chest should have been done, which is not invasive, and correct diagnosis would have been made at that time because chest X-ray may miss lesion at times.
No, over here, the chest X-ray is showing lesions.
No, it was in the beginning of the case. when he
Beginning
was
of the
not
case,
in the
that is,
private setup.
yeah, in the private setup. So if you look at that X-ray in the left lower
Yes,
zone, there are infiltrations which were ignored probably, and I think the sputum was not done that time.
At that time,
At that time, so that was one thing, the disease had started at that time only. That was the reason we included this part in the beginning. We started the case presentation right from that point. Although that time the child did not have fever, cough, and no chest symptoms. It's just presented with blood hematemesis, fresh blood.
Fresh blood during coughing.
During
But,
coughing.
after admission, they do the endoscopy.
They did
That
the
it may
endoscopy.
be-
So that is one thing which was missed, and at that time also the sputum smear came positive. So they could have easily done after that.
After that.
In the second episode when the child was admitted, this time with chest complaints.
July,
That time,
July.
yeah, July. That time the sputum smear was positive.
Yes, ma'am.
And sputum smear was positive.
Yes,
First
yes,
and
yes.
second line LPA should have been done there. Because sputum smear was positive there.
Okay, thank
So,
you, ma'am. Yeah, there's one question. Any role of phenotypic DST to rifampicin due to molecular test discordance?
There is no role of phenotypic DST to rifampicin. The genotypic DST has, for rifampicin, it is genotypic DST which is taken into account.
Yeah. So we have two questions. Dr. Rajendra Prasad, sir, you want to make a comment?
Sangeeta said, it is very right, but any test may go wrong in one of the particular patients. So there is no harm in a phenotypic rifampicin sensitivity. Because ultimately we say that phenotypic is probably the gold standard. But this is very difficult scenario. This is very difficult case. So here in this scenario, what is my thinking? You have to be you have to think out of box, and you have to think of everything what can happen in even a single patient. So those things has to be kept in mind. Thank you.
Thank you, sir. Dr. Ritu, you wanted to make a comment?
Yeah, ma'am, thank you. Since, it's just a topic of interest, so I would like to add on, though my seniors, Dr. Sangeeta ma'am and Dr. Prasad sir have already given. But just to clarify that, phenotypic DST no longer is considered gold standard. So we have to, if in this case, we could have considered probably target or some other sequencing is what could have been considered in case we are not, if the genotypic DST by LP is not giving the adequate answers, that is one thing that could have been done. Am I audible, ma'am?
Yeah. Yes, Dr. Ritu.
Yeah, that's all. So I would just say that we could have probably thought of considering sequencing in case it's not giving adequate answer, but phenotypic DST would not be advisable also because the breakpoint concentrations at time can be misleading also in case of mutate.
Okay. Thank you, Dr. For information of the house, Dr. Ritu is the microbiologist at NITRD. Thank you, Dr. Ritu. We have a question from MODTC Ganjam. Yes, sir, your question.
Good afternoon, everyone. Actually, it's a different type of question, not related to the case. So my request is and submission is, please draw a proceeding after end of each session with inference and share it with all the DTOs and DRTV centers. So
Yes.
that will be a great help while treating a difficult case.
Right, sir, we'll do that. Your
And-
point is taken. Thank you so much.
And also please share the PPT also with all the details and DRTs.
Sure.
Thank you.
Yeah. So, are there any questions, comments, questions from the house? Okay. So, I would now like to take final comments from Dr. Singla.
And I think, as we discussed, Dr. Sangeeta also mentioned, I think we are on the same plane. Can you show the slide again? So she has suggested WGS, provided we have a reliable standardized laboratories available that may help us, especially in view of the molecular mutations, to see if mean will be of use or not. And I think, Dr. Sangeeta, this is, I think both of us are saying the same thing.
Yeah.
So the blood level should be done, she emphasized several times. So in case blood levels we find it normal, in that case the regimen could be the delaminate, amikacin, ethionamide and PAS plus moxifloxacin high dose and linezolid. In case the blood levels are low, in that case delaminate, because we like to give more of injectables in that case. So delaminate, amikacin, ethionamide, PAS, injectable moxifloxacin which is available. You see very few ATD drugs are available in injection form. So here we would like to prefer the drugs which are available in the injection form. So delaminate, amikacin, ethionamide, PAS, injection moxifloxacin, and we can consider adding injectable INS like streptozide. This name is it used to be available. I'm not sure whether it's available now or not. And rifampicin high dose.
Rifampicin is available as IV.
Is it available in India?
Yeah.
If it is available, well and good. In case it is available, very good. And injectable INS. So this could make a regimen in both the scenarios.
Okay, thank you, Dr. Singla. So, one of the important things that we have to keep in mind is that bedaquiline resistance is coming up, and we have to be very conscious of using shorter regimens and longer regimen, as both have bedaquiline. We have to use it very wisely, and if we are using it, we should be supervising the patient thoroughly. So again and again, every case it is coming up, that the patient is either not going to DTO or the DTO is not able to see the patient. So that interaction is missing somewhere in the field. And that is where the question of, follow-up cultures is also coming up. In most of the cases that we have discussed in previous clinics, we have seen that, follow-up cultures are missing. So one of the challenges or the gap that we see in different cases is, patients are not meeting the district TB officers, not getting their follow-up cultures done, and they are not being monitored in the field. So that is very important. Pertaining to children, as you said, nutrition is important, but one doesn't have to go out of way to add expensive things.
Fancy foods.
Yeah, so just give seasonal foods and deworming. That's a very good thing, once to deworm the child before giving the medicines. And again, therapeutic drug monitoring is needed. We have been saying it in our different clinics, that for some specific patients who are not responding to treatment, there is a felt need for, therapeutic drug monitoring, and we should have this in every state or region or whatever possible, but that is a felt need of the patient now, that we should have this. And as Dr. Singla said, for this patient, we will have to go through this TDM, do the therapeutic drug monitoring, and devise the regime based on what we get there. And meanwhile, I think we continue with the, what regime that you have made, and as patient is getting most of the medicines.
And child has started to improve, the recent chest X-ray has shown improvement. But still fingers are crossed and we are working on it.
Yeah.
You see, another thing is the like in follow-up, the culture was positive. No action was taken. So again, that is not a good thing that people do not look at the Nikshay and see what the reports are coming. And in the bargain, what happens in case patient is taking particular regimen, cultures are continuously positive. We are developing more and more augmentation of the resistance to the other drugs to which they are not resistant to. Not only that, suppose initially the resistance was to the tune of 10% to a particular drug. If you keep on giving that, it may become 50%, it may become 100%. So this drug totally becomes useless for us. And additionally, we will be having the adverse drug reaction to the drugs which we are giving. So they are not effective, but yes, they are giving the adverse drug reaction to the patient. So we have to be very, very careful, especially in the shorter or the longer regimen. They are all toxic drugs that we should do the cultures at time and take action on time so that we don't miss out on this opportunity to change the regimen at an appropriate time.
I would like to have your last comments on the TPT, the TB preventive treatment for children. If there is a DRTB patient at home, and that's very, we know that we are not giving it at the moment, but what is your take and what is the thing that we should keep in mind?
No, now the program has introduced TPT for DRTB. So for MDR TB patients, the program is giving 6 months of levoflox or moxiflox depending upon the resistance pattern of the source. And for INH resistant source, the regimen which is given is 4 months of rifampicin. And the other thing which is important is that till the child sputum converts, to wear a face mask, to have the airway, cross exchange, etc. Those measures needless to say. But mind you, children are children and siblings are siblings. So this is all on book or paper, but in fact, we need to start after assessment. That first we need to rule out active disease in the context. For information of the house, the child's brother has reported and is sputum positive. So that means already one sibling has to be put on the. We are sending all the investigations for that child, and the other siblings. Obviously, we are doing the assessment. After the assessment, that includes the chest X-ray, and depending upon the age, either the sputum or the gastric aspirate, we would be sending to rule out the active disease, and then we would be starting the prophylaxis.
But in this case, Leo is resistant. In this
No,
case,
actually,
Leo is
levo is
sensitive.
sensitive.
But maybe resistant because of the failure.
Yeah, in case it is levo or moxi resistant, that is important. Then there is no regimen which is right now available under the program. Then it is, we don't have anything to offer as a TPT for a DRTB context.
We need to just follow them up.
Yeah.
That is the only available thing in such cases.
Yeah. And pyridoxine, mind you.
Yeah.
Addition of pyridoxine whenever you're giving a TPT. And then after completion of TPT to follow up for 2 years.
Right.
That is recommended under the program.
With this, I think we will close the session. Before we close the session, we'd like to take your feedback. There's a link given in the chat. Please take this fill in this feedback form. It is very important for us to improve. So we would look forward to having your feedback. And with this, I would like to thank everyone who has joined the clinic today. We would like to thank DDG sir, who's always there, to support us. The National Task Force is there. And of course, the NITRD, the faculty who's here, and all other faculty who have joined. And I would also like to thank Echo India, Ms. Shifa and Mr. Manjeet, who are supporting this clinic. So thank you very much for joining. Thanks a lot.
Thank you. And thanks to Find also,
Yeah, a very
And
big
we-
thanks to Find
yeah.
because they are the ones, you know, who have supported this clinic this time. Thank you.
And we have
Find.
had good clicks this time. Nita, what was the click rate?
Yeah, almost 370 people joined at one time.
People will be more. There are so many hubs, so many not hubs. What do you call it?
Sites.
Sites.
Hmm.
And sometimes at one side more people are sitting, very commonly.
So thanks one and all, you know.
Thank you.
Thank you.